So my job is to give comment upon the comments. So starting with the last presentation, that was radiotherapy role in an ADT role in those oligometastatic disease. It may be inconceivable that you won't give systemic therapy in metastatic disease because you're giving it in your high risk and intermediate risk group. I was impressed that with ethics committee, and it's good to do it. Don't get me wrong. I do agree. CT scan wise picking up metastatic disease and PET scan wise picking up metastatic disease, they may have a different biological behavior. But this is a good example to convince our ethics committee to allow these kind of studies. Think about stage 4 and you say, hey, I'm not going to give you ADT. That was the design. Only give RT and RT plus, it was RT plus ADT. ADT and ADT for 6 months. Impressive. Not giving ADT beyond 6 months, and we debate here when to stop it. And I think, urologists, we keep debating. Once you start ADT, either you orchidectomy or still CRPC, it continues. We never stop it. So that was a very good design, to have it, because we debate that we need to stop it early, not necessarily we'll need for 5 years, 7 years, which we keep giving. So interesting design. How to implement will be a challenge. How someone will take this project further, that will be a challenge. I didn't see that where it was done, which place. And the drug is very good. Oral, we are all looking for. I wish we get oral. But I think so. Orchidectomy remains, I think so, easiest, and most of our patients they do that. Take that. Coming to a presentation for cabazitaxel Bursal luteation PSMA, I think so. PSMA luteation therapy is going to come. It's going to keep creeping. We have seen now 2 data. Looks promising. Looks that it will come in some form and some combination. Only it's bit more toxic than what we have thought about. And same is in that clinic, that trial, the previous trial which was there. But response was impressive, 40%. That was the response in the previous study. So looks here, they interpreted a non-inferior. Number was too small to interpret that, but curve looks good. And if something is as good as cabazitaxel with the similar curve, and you give once in 6 weeks, most likely we'll choose that. Looks so, luteation PSMA will keep creeping in. That's the way we look for. Phase 1 CAR T cell, we sincerely hope. We are struggling with CAR T cell in solid tumor. Doesn't look like, we have some leads somewhere we keep seeing, but not those leukemia responses. We have not seen those leukemia responses that going into CR, except once in a while we have heard that. Pembrolizumab and olaparib, again here looks like olaparib is in. We'll keep debating where we are going to use. HRR, BRCA1, all combination. Immunotherapy is struggling. Again, we are not able to see in prostate cancer immunotherapy really showing something, good, responses. There have been, ways to have TMB, high TMB, select them, MSI high, and then select and treat them. That can be subgroup, but doesn't look like it is doing an impressive job. Talazoparib and enzalutamide, and yes, again I say PARP inhibitor is in. We will slowly will learn which one and where to use and which place, and BRCA1 or HRR or all comers. BRCA looks like we concede that in BRCA positive patient, it works. Rest will learn as the time goes by. Darolutamide, a very safe drug. It is really safe. Whenever we have used in clinic, not many, but looks like if we get something cost-effective darolutamide, it has a capacity to replace all others what we have at this moment. At the Rebretron, enzalutamide looks like with the SCOT order, it will be out of the market. We'll end up having only original, and it will be tough to use. But darolutamide also today remains in Indian context only original. But safety-wise, excellent drug to have. So again, we'll have more data regarding this drug in future. Coming to oligometastatic disease, we'll keep hearing. Oligometastatic disease, we do know there is a metastatic disease patients in almost any site. And this concept keeps coming up everywhere. We have in lung, in head and neck we talk about it, where it is tough to make it oligometastatic because all the head and neck which comes are oligometastatic only. But we are not able to do much. So there was some skin lesion and it was a discussion in our JC that is this oligometastatic disease and can we treat like that? Thankfully sanity prevailed and we say no, give systemic therapy right now, wait for 6 months and then we'll see it again. But majority of the site it will keep coming because we have seen with this PET based diagnosis of metastatic disease that those biologies are different. These patients, they will have metastatic disease, but a group of them keep doing very well. And that is where we want that they shouldn't grow. So we will have those struggles that how we are going to treat them. Lung cancer, not lung cancer, 2 randomized trial in oligometastatic disease with local treatment with radiotherapy. Positive, they had to stop it because it was so good. Third one in lung cancer, it was so good. But the problem is that they're competing with the systemic therapy. So in lung cancer, by the time the trial happens with gefitinib osimertinib is there. So again going back, so lung trial again was stopped because of the PFS was so good with adding the local treatment. So DSMC, data monitoring committee didn't allow them to continue that study. It is doubling of the PFS. But again, in the clinic, by the time osimertinib has come in, so now someone is doing another study. So that's competition will go, and it's a good competition. So we will have many more, we'll see, we'll keep hearing about oligometastatic disease in near future. I hope I have not taken a long time. Thank you so much.